We're at the 7th conference, the IAS meeting in Kuala Lumpur with Jenny Hoy, who is from the Alfred Hospital in Monash University in Melbourne, Victoria, Australia. And we're very pleased that you took the time to visit with us because it's on a subject that is near and dear to many people's hearts, and that is the any improvements or any discussion we can have about metabolic issues. And this one might be covering issues around bone loss and drugs that are going to cause less of it. And so why don't you set that up? The background, I think we want to go with first.
So as many people now know, that HIV positive patients who are on antiretroviral therapy have a significantly greater rate of osteoporosis and fragility fractures. And that loss of bone appears to be related to some of the types of antiretrovirals that the individuals are taking, with tenofovir and the nucleoside analogues being particularly associated, as well as the protease inhibitors. The integrase inhibitors and loss of bone, that issue is not well defined at this point in time.
Because it's maybe too early.
It hasn't been looked at
particularly.
No. So we know that patients that start therapy have about a 3 to 6% loss of their bone mineral density. And bone mineral density is the strength of the bone, and it's measured on a DEXA scan. And after that first year of therapy and that 3 to 6% sudden loss, the loss then appears to stabilise in some studies. In other studies there is continuing loss, and in the SMART study, where patients had been on therapy for over 10 years, the loss of bone each year is similar to that lost by postmenopausal women, so a significant loss of bone. We looked at the changes in bone mineral density in the second line study. Second line was a study that looked at the most appropriate regimen for patients in low and middle income countries who had been on a non-nucleoside reverse transcriptase inhibitor first line regimen and were failing. So this was a group of patients with virological failure on their first line regimen, and they were randomised to either change to the current WHO recommended second line regimen, which is 2 to 3 nucleoside analogues plus a boosted protease inhibitor, usually lopinavir, ritonavir. And the experimental arm in the second line study was a nucleoside analogue free arm. And it was using raltegravir with the lopinavir, ritonavir. And there were patients enrolled in many countries, low and middle income countries. The bone sub-study, however, was done in middle income countries that had access to DEXA scanning so that we could look at changes in bone. So there were 8 sites in 5 countries.
This was nested within another larger
This was
study?
nested within the second line study. So the body composition or bone sub-study was a component of a larger study. And there were 210 patients who had an entry DEXA scan and another DEXA scan at week 48. And what was good about this study was that 52% were women and 97% were non-Caucasian. And most bone studies have been done in Caucasians and often in men. So this was going to be much more generalisable to the HIV population worldwide, globally. So in the study, the change in bone mineral density in the WHO recommended regimen, the 2 to 3 nucleoside analogues and lopinavir, was about 5.9% at the hip and 5.2% at the spine. That's quite a significant drop. In the experimental arm with the raltegravir lopinavir, the percentage drop was 2.9 at the hip and 2% at the spine. So there was a significant, statistically significant difference between the two arms with the loss of bone mineral density. And the magnitude of that loss, the magnitude of reduction in that 2 to 3 nucleoside analogues plus lopinavir, ritonavir, was similar to that you would see in antiretroviral naive patients starting therapy. So much greater than what we see in suppressed patients who change their regimen for toxicity reasons. If you look at the Steele study or a study done by some Danish colleagues, the rates of bone mineral density loss were about 1 to 2%.
Now, do you think this would continue on out?
So this is the week 48 results. We don't have the week 96 results yet. They will be available. We will be able to see whether they stabilise or whether there's a continuing loss at that rate. I suspect that they will stabilise and the loss will be less after that 48 weeks. So this, in my mind, confirms that loss of bone mineral density and bone disease is going to remain an important comorbidity in treated HIV patients.
It's very relevant.
Yes, it is.
I mean, I think most of the people that are living with AIDS today are in it for the long haul.
Yes.
They're going to figure out, okay, because like we said earlier, the regimen that you're going to be on is going to maybe be for many, many years.
Yeah.
I mean, it could be. And I'm one that doesn't like to switch unless it makes sense to do so. So here's maybe a reason, if you. But of course, we want the doctors to get invested in this too.
But in this second line study, the individuals needed to switch because they were failing their first line regimen.
So what to switch to would be the other would be the question, and make good sense. So let's see. We're going to talk about something else. So
the other important study that I think is currently underway is the START bone mineral density sub-study. The START study is looking at the when is the right time to start antiretroviral therapy, and is looking at more than just survival and progression to AIDS. It's also looking at cardiovascular disease, liver disease, and there is a bone disease sub-study. And with bone disease being one of the few organ systems that continues to get worse on therapy, I think it's an important sub-study because we need to know in the long term whether untreated HIV has an impact on your bones and how much impact it has, and what the impact is of the antiretroviral therapy. So we've recruited 420 patients to that sub-study. The sub-study recruitment is completed. Yes, it's fully enrolled, and now we're in the process of following all of those patients.
How long will it be till you get the answers to your questions?
For the bone sub-study, it will cease when the main sub-study ceases, and that main sub-study with the 4,600 patients that's not fully recruited yet. There's still a few hundred to go, but it will be fully recruited in the next few months. Once there is an answer to the question of events in either arm being significantly greater, and those events include the non-communicable diseases that I mentioned, the cardiovascular disease, liver disease, renal disease, etc. includes the AIDS-defining illnesses, and it includes survival. So there's a composite endpoint, and once that endpoint is reached, all the sub-studies will stop as well.
So you have a year or so?
I think it will be longer than a year. I think it will take a couple of years.
And I think a few people said that maybe the WHO guidelines were premature and wait for the, to make the shift up on the numbers rather than to just wait until after some study like the START study would be. But, it's kind of like at the point where, there's a lot of, we have some data, but I think this would be more informing. The START study.
Yeah, the START study would be the randomized study. And I think it's interesting that different guideline groups look at the same studies and come out with a different recommendations using the same information. And there is a range of recommendations and guidelines around the world, from treat everybody to treat less than 500 to treat less than 350. And the evidence and the reasons why the guidelines come up with different answers, I think, are interesting around the world as well.
But they are guidelines, and we are not treating numbers, we're treating people.
Exactly.
and I think that's the one thing. Once they go by the book, but then they throw the book out when they say this is the reason why.
And I think there will be some patients who want to start treatment straight away, and there will be others that do not want to start treatment straight away. But if we have some good evidence to say that's not a good idea to wait, and we really think you should be starting now for these reasons, then that will be useful. Yeah.
Well, I thank you very much for your participation in our video interviews that we do here at the IAS meeting.
Okay.
We do the CROI as well. I appreciate that, and definitely want to have you back when we have the answers in 2 years or less.
2 to 3 years.
2 to 3 years or less. Thank you so much.
All right. Thank you.